Patients here.
Oh boy, got some blood going.
Yeah, this is with blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Okay, picture this scenario. You are sharing your home with a scientist, a very small, very determined scientist. This scientist, they conduct these dangerous physics experiments on your furniture every single waking hour. They have absolutely zero sense of self-preservation, and they actively resent any assistance you try to offer.
And crucially, this scientist is likely wearing a diaper and stands about, 30 inches tall?
Exactly. We are diving deep into the toddler years today, ages 1 to 3.
The fun zone.
Right. We often hear that phrase terrible twos, but when you look at the stack of research we have on the desk here, the textbook chapters on growth and development, the lecture slides on physiology, and the absolute beast that is the CDC's 2025 immunization schedule, calling it terrible just feels a bit lazy.
It's reductive, isn't it? It frames the child as the villain, when what we're actually looking at is a clash. It is, I would argue, the most explosive collision in human development.
A collision between
a body that can suddenly move. I mean, really move, run, climb, access the whole world, and a brain that has absolutely no logic, no judgment, and, zero impulse control.
That is the mission for this deep dive. We're stripping away all the generic parenting advice, and we're talking directly to the learner. Whether you're a nursing student sweating over the NCLEX and trying to memorize milestones, or a parent just trying to deconstruct why your kid had a meltdown because you gave them the wrong blue cup.
Yeah.
This is for you.
We're going to use the 80-20 rule here. In nursing education, we talk about this all the time. Instead of just memorizing charts in a vacuum, we're going to focus on the core concepts that explain everything else.
Okay.
Specifically, we're going to look at the collision between Jean Piaget, who explains how they think, and Erikson, who explains how they feel.
Because if you understand those two things, the thinking and the feeling, everything else just falls into place.
Everything. The safety risks, the way they play, the potty training struggles, it all stops being this random chaos and starts looking like, logic.
Flawed toddler logic, but logic nonetheless.
Exactly.
So let's start with the big picture, the developmental headline. We're calling this phase the autonomous explorer.
Right. And if you remember infancy, the whole theme was trust and dependence. The baby needed you for literally everything. Toddlerhood is the violent swing to the opposite side of that pendulum.
Complete opposite.
The defining theme is the struggle between that old dependence and this desperate, burning need for independence. This is Erikson's stage of autonomy versus shame and doubt.
The era of me do it.
Precisely. Me do it.
Yeah.
They want to control their body, their environment, everything. But here's the fascinating biological context that I think often gets missed.
Okay.
While their desire to move is speeding up, their actual physical growth is hitting the brakes hard.
And this is a huge shift from that first year, right? In infancy, growth is just explosive. They triple their birth weight.
They do. It's incredible. But watch what happens between age 1 and age 3. The growth velocity just creates this massive deceleration. If you look at the textbook sources, a toddler only gains about 4 to 6 pounds per year.
Wow.
And height-wise, it's only about 3 inches a year.
That's a crawl compared to the baby phase. And this leads to a specific phenomenon that, it freaks parents out constantly. It's called physiologic anorexia.
And the name itself sounds so clinical, so scary.
Yeah, it sounds like an eating disorder.
Exactly.
Yeah.
But it's just normal biology. Because that growth engine has idled down, their metabolic need for calories just plummets. They simply aren't as hungry as they were when they were 6 months old.
So the parents are sitting there at the dinner table, they're watching their kid eat like one bite of a hot dog and push the plate away, and they just panic.
Total panic. They think, he's starving, he's going to wither away.
Right.
And the nurse's role here is so crucial. You have to reframe that. You have to explain, look, this isn't a behavior problem, it's an efficiency problem. They just don't need the fuel.
And if you force it.
If you force feed them here, thinking you're solving a nutrition problem, You are actually creating a psychological battle over autonomy. And guess what? The toddler will win that battle every single time.
Let's talk about the chassis of this little vehicle. They don't look like miniature adults yet. They have this very specific kind of comical build.
Oh yeah, we're looking at the classic potbelly and sway back. In medical terms, we call it lordosis, that inward curve of the spine.
And parents often worry about this. They see the belly sticking out and they think it's, I don't know, bloating or dietary issues or something.
But if you look at the physiology slides, it's purely muscular. The abdominal musculature is just incredibly weak at this stage. It hasn't tightened up enough to hold the contents of the abdomen flat.
Like a girdle.
Exactly. That muscular girdle doesn't really form until around age 3. So gravity takes over, the belly protrudes, and then the back has to curve to compensate for the weight.
And there is one other physical feature we absolutely have to flag because it becomes a major physics problem later on: the head.
The head is the hazard. By age 2, a toddler's head is already 90% of its adult size.
90% on a body that is what, a fifth of the size of an adult? That's insane.
It is. They are massively top-heavy. Their center of gravity is so much higher than yours or mine, it's right around the chest level.
And this isn't just a cosmetic note, right?
No, this dictates how they move, how they fall. When a toddler trips, they don't have the mechanics to catch themselves easily. The weight of that head just acts like a pendulum and pulls them straight down.
Which, as you said, foreshadows our safety discussion later regarding drowning and falls. But before we get there, let's map out this danger zone. This is the gap between what they can do versus what they cannot do.
This gap is everything. It is where the accidents happen. It's where all the ER visits come from. Developmentally, their motor skills are skyrocketing. But their judgment, it is basically non-existent.
Let's walk through the can-do milestones then. If we're looking at a 15-month-old, what are we seeing?
Okay, at 15 months, the walk is usually established, but it's that specific toddler gait. Feet are wide apart to create a broad base of support, and the arms are held up in high guard for balance.
They look like they're surrendering.
They do. It's very cute. They can also creep upstairs, usually on hands and knees. And fine, motor-wise, they are messy. They can use a cup, but they'll spill it. They can use a spoon, but they'll rotate it upside down right before it gets to their mouth.
Classic. Then we hit 18 months, and this feels like a really significant jump in the literature.
18 months is the shift from wobbly to mobile. Now, they are running. It's clumsy for sure, and they fall a lot, but they're fast. They can jump in place with both feet, and they can throw a ball overhand.
Which means they have an aim. Oh, boy.
Exactly. And there is a critical exam note for 18 months regarding anatomy. The anterior fontanel.
The soft spot on top of the head.
Correct. The posterior one in the back, that closes really early, usually by 2 months old, but the anterior fontanel, that big diamond shape on top, must be closed by 18 months.
And if it isn't?
If you're examining an 18-month-old and it is still soft or bulging or sunken, that is a big red flag for a neurological issue or a hydration problem. It should be hard-boned by now.
Got it. Closed by 18 months. Okay, now let's fast forward to the big one. The terrible 2 mark. 24 months.
2 years old. This is the era of the doorknob.
The doorknob. It sounds so trivial, but that changes everything, doesn't it?
It changes the entire safety profile of the home. Before this, a closed door was a wall. Now it's just a delay. They can turn knobs, which means the bathroom is accessible, the garage is accessible, the front door is suddenly accessible.
Combine that with the fact that they can now walk up and down stairs, usually placing 2 feet on each step, right?
Right, 2 feet on each step. You've got a creature that can breach almost any containment you've set up.
And by 36 months, age 3, they're just refining all of this.
Totally. If we're riding a tricycle, they're balancing on 1 foot, they can even copy a circle.
So looking at that whole list, they are mobile. They can climb, open doors, throw things, and run. That's the can do. What does the cannot do?
This is the scary part. They cannot reason cause and effect effectively. They cannot differentiate between a safe liquid, like, say, apple juice, and a poison, like floor cleaner. Their taste discrimination is still really poor.
Okay.
And, most importantly, they cannot inhibit impulses.
Let's unpack that impulse control piece for a second, because parents get so frustrated here. They say, I told him no 5 minutes ago, and he looked right at me and did it again.
And the parent assumes defiance. They think it's a power struggle. But physiologically, the neural pathways in the prefrontal cortex, the ones that are supposed to say stop, don't touch, they just aren't myelinated yet. They aren't connected.
So they might know the rule.
They might. They might intellectually know the rule, but when the impulse strikes, the action happens faster than the brain can pump the brakes. They They literally cannot stop themselves.
So it's not just stubbornness, it's a wiring issue.
Like a developmental limitation. Expecting a 2-year-old to have reliable impulse control is like expecting them to do calculus. The hardware just isn't there yet.
That explains so much. Okay, let's dig deeper into that brain. We talked about the motor skills, now let's talk about the mind. Piaget.
Jean Piaget. He's the key to understanding the cognitive side of all this. Toddlers are in this big transition from the sensorimotor stage, which is infancy, learning through touch and taste, into the pre-operational stage, which goes from about age 2 to 7.
But in that transition, between 12 and 24 months, there's this fascinating phase called tertiary circular reactions, which sounds like a term from a sci-fi movie.
It does, but it's just a fancy way of saying active experimentation. This is the little scientist that you were talking about at the beginning.
So give us an example of how this looks in the wild.
Okay, so a baby might drop a spoon by accident and be surprised by the clang it makes. A toddler drops the spoon on purpose. Then they pick it up and throw it hard to see what happens. Then they push the whole bowl off the high chair tray.
They're gathering data.
That's all it is. They aren't trying to be bad. They're testing variables. If I drop this, does it make a loud noise? Does it bounce? Does mommy pick it up? What happens to mommy's face when I do it for the 10th time? They're learning about gravity and sociology all at once.
So it's active learning through trial and, well, a lot of error.
And a lot of mess.
Right. And what about object permanence? That's fully established now, correct?
It is. They know the object exists even when it's hidden. In infancy, out of sight was out of mind. Now, they know the cookie's in the jar, and the jar's in the cabinet. They can hold that image of the object in their mind.
Which explains the persistence. They know the goal is there, even if they can't see it.
And clinically, this is why separation anxiety persists. They know the parent exists in the other room or at work, and they want to be there. The concept of you doesn't disappear when you walk out the door.
Now, as we move into that pre-operational thinking, usually post-age 2, we see some really distinct thought patterns that define this age. And the biggest one is egocentrism.
This is the one that gets so misunderstood. When we say a toddler is egocentric, we don't mean they're arrogant or selfish in the adult sense of the word.
It's not a character flaw.
No, it's a cognitive limitation where they literally cannot see the world from another person's perspective.
The classic example is the TV, right?
Yeah. A toddler stands directly in front of the TV while you're watching it. You say, hey, move, I can't see. They don't move. Why? Because they can see the TV just fine. And if they can see it, they genuinely assume you can see it too. They cannot compute that your visual field is different from theirs.
That is just wild. And it applies to feelings too, I'd imagine. If they're happy, everyone must be happy.
Precisely. If they're sad, the whole world is sad. This is why they can't effectively empathize yet. They might pat your back if you're crying because they've seen you do it, but they don't intellectually grasp your separate individual pain.
Then we have animism. This is attributing life and feelings to inanimate objects.
The bad table, this is my favorite. The toddler runs, bumps into a coffee table, hurts their knee, and immediately turns around and scolds the table. Bad table. In their mind, the table did it on purpose. It's an aggressor.
This has to have huge implications for healthcare and nursing.
Massive. Think about a blood pressure cuff or an IV pump. To an adult, it's a tool. To a toddler operating with animism, that machine is a monster that is intentionally squeezing your arm. It's alive and it's mean.
So how do you handle that? What's the nursing intervention?
You have to demystify it.
Yeah.
You have to play into their reality. You let them touch the equipment. You talk to the equipment. Okay, Mr. Cuff is just going to give your arm a little hug now.
Yeah.
You have to engage with their world, not try to pull them into yours.
And then there's magical thinking.
This is the belief that their thoughts can cause real-world events. It's very powerful and honestly very dangerous for their emotional state.
Give us a scenario.
Okay. Let's say a toddler is jealous of a new baby sibling. They have a moment of intense anger and think, I wish the baby would just go away. The next day, the baby gets a little fever and has to go to the doctor. The toddler believes they did that.
Oh, wow. They think their thought caused the illness.
They think their thought was a weapon. This creates immense unspoken guilt. And as caregivers, we have to explicitly reassure them, you didn't make the baby sick. Germs made the baby sick. You have to break that magical link for them.
So we have a child who thinks tables are alive, their thoughts are powerful magic, and everyone sees exactly what they see.
Correct. That is the operating system of a 2-year-old. It's a trip.
Now let's layer Erikson on top of that, the emotional engine. We said it's autonomy versus shame and doubt.
Right. The goal is control. They are realizing they are a separate person from the parent, and they want to drive the bus.
And their weapon of choice is negativism.
The almighty power of no. And listener, if you take one thing away, please internalize this. No is not disrespect at this age. It is an assertion of self.
Explain that more.
If I ask you, do you want to eat? And you say yes, you are agreeing with me. You are following my lead. But if you say no, you are standing apart. You are an individual with your own will.
So even if they are starving and want that cookie, they might say no.
Constantly. They will refuse something they desperately want just to prove they have the agency to refuse it. It's a declaration of independence.
So how do you hack that? How do you parent or nurse a machine that just runs on no?
You never, ever ask a yes-no question if you need a specific outcome. Do not ask, do you want to get dressed? You're just handing them a loaded gun.
So what do you do instead?
You use the forced choice. You say, it's time to get dressed. You want to wear the red shirt or the blue shirt?
You frame the autonomy within your goal.
Exactly. You give them the illusion of control. They get to pick the color, but you control the ultimate outcome. They get dressed. It satisfies their Eriksonian need for autonomy without completely derailing your morning.
And what about ritualism? This need for really strict routines.
Think about how scary the world is when you are small, you have no judgment, and you think tables are out to get you. It's absolutely chaotic. Ritualism is the anchor in that storm.
The same bedtime story read the exact same way, the same cup, the same order of putting on pajamas every single night.
It provides a sense of safety and predictability in a world that feels random and overwhelming. If you break the ritual, you break their sense of security.
This has to be huge in the hospital.
Oh, it's number one. If a kid is admitted, the single best thing a nurse can do is ask the parents about their home rituals.
Right.
What cup does he use? Does he sleep with a specific blanket? What song do you sing? And then you try to replicate that structure as much as humanly possible.
And when the stress gets too high, say, a new sibling arrives or they get sick, we see regression.
Right, they go backward. A potty-trained child starts wetting the bed again. A child who speaks in full sentences goes back to pointing and using baby talk.
And the advice there is,
don't punish it. It's a defense mechanism. They're just retreating to a time when they felt safer back to infancy. If a new baby arrives and the toddler suddenly wants a bottle, don't shame them for it. But you also don't want to reinforce it too much.
so you don't give them the bottle.
The best practice is to sort of ignore the regression. You don't make a big scene about the baby talk, but you lavish praise on the age-appropriate behavior. Wow, look at you helping me with the diaper. You are such a big helper. You validate the growth, not the retreat.
Okay, so we have the mind, which is Piaget, and the drive, which is Erikson. Now let's connect this all to safety. This is the cause and effect segment of the deep dive. Why do toddlers get hurt in such specific ways?
This is where we apply what we call the unsafe explorer model. We had to link the cognitive limitation directly to the physical risk. Let's start with aspiration and choking.
The classic grapes and hot dogs.
Right. The cause here is a mix of sensory exploration. That's Piaget again. They put everything in their mouth to learn about it. And simple anatomy. Their airways are tiny, about the width of their pinky finger. So coins, batteries, hard candy, nuts. They explore, they inhale by accident, and they choke.
What about drowning? This links right back to our physics lesson about the head, doesn't it?
It connects directly to that top-heavy concept. A toddler is curious. They see a toilet or maybe a 5-gallon bucket of cleaning water on the floor. They lean over to see what's inside.
Curiosity leads the way.
And their center of gravity shifts past the pivot point. They tip forward, and because their head is so disproportionately heavy, they fall in head first. Now here's the absolute tragedy of it.
They can't get out.
They do not have the upper body and neck strength to push themselves back up. They are like a turtle on its back.
So they can drown in a tiny amount of water.
Inches. They can drown in a toilet bowl because they physically cannot lift that heavy head against gravity to get air. That's why bathroom doors must be kept closed or latched at all times.
That is a chilling visual, but it makes the risk so incredibly clear. What about burns?
This is locomotion plus a lack of cause and effect. They can climb onto a chair, reach the stove, and grab a pot handle. They see the handle, they want to explore it. They don't have the cognitive link that says handle equals very hot liquid that will hurt me.
So the guideline is always pot handles turned inward.
That way. And water heaters need to be set to below 120 degrees Fahrenheit. Because remember the doorknob skill. They can turn on faucets now. If the water comes out at 140 degrees, they can get a third-degree burn in seconds, long before they can react and pull their hand away.
Right, the motor skill outpaces the judgment again. That leads us directly to poisoning.
It's the same skill set. They can open the cabinet under the sink, and because of that poor taste discrimination, they won't necessarily spit out a chemical just because it tastes bad. They'll just swallow it.
So everything high up and locked.
High and locked. And finally, motor vehicle injuries. This is a big one for parent education because the guidelines have shifted over the years, and not everyone is up to date.
The rule is rear-facing until at least age 2, or until they max out the seat's height and weight limits. So why?
It's physics again. We have a heavy head and very, very weak neck muscles. In a forward-facing crash, the body is held back by the straps, but the head flies forward violently. The neck muscles can't stop that momentum, and you risk what's called internal decapitation, or a severe spinal injury.
Internal decapitation. That is a terrifying phrase.
It is, but it explains the why. A rear-facing seat creates a shell that cradles and supports the head and neck. The seat itself absorbs the force of the crash, not the child's tiny spine. It's not a parenting style choice. It's pure anatomy and physics.
Okay, let's pivot to something a little lighter. Play. We know they're little scientists, but how do they interact with other little scientists?
They really don't,
Yeah.
at least not cooperatively. The style of play for this age group is called parallel play.
Playing alone, but together.
Perfect way to put it. Imagine two toddlers sitting on a rug. They're both playing with blocks. They're sitting maybe 2 feet apart. But they are not building a castle together. They are each building their own separate tower, completely ignoring each other, yet somehow finding comfort in the other's presence.
And this links back to egocentrism.
100%. They literally cannot understand the concept of sharing or having common goals yet. To share, you have to understand that the other person wants the toy and has feelings about it. The toddler just sees my toy.
So forcing them to share is just a losing battle.
It's developmentally inappropriate. You can model it, you can encourage taking turns, but you cannot expect true cooperative play. They are just not wired for it yet.
What about the toys themselves then? What should we be buying or, recommending for this age?
We want toys that support their big developmental tasks. For locomotion and that drive for autonomy, push-pull toys are absolute gold. Those little lawnmowers that pop or vacuums they can push around.
It rewards the walking.
Exactly. For fine motor skills, we look at blocks. And the data shows a really clear progression. At 18 months, they should be able to stack maybe 3 to 4 blocks. By 24 months, it's up to 6 to 7 blocks.
That's a pretty specific metric.
It is, and it's a great, simple way to track their fine motor control and hand-eye coordination. Also, thick crayons and finger paints. Anything tactile.
And I saw something in the notes about pounding toys, like those little wooden benches with the hammers and pegs.
Oh, those are fantastic.
Mm-hmm.
They're great for releasing aggressive energy. Toddlers have so much frustration. Remember that gap between what they want to do and what their body can actually do. Pounding a peg allows them to release that frustration safely without, hitting their sibling.
It's therapeutic hammering. I like it.
It really is. It channels that very normal, aggressive impulse into a safe and appropriate activity.
Okay, let's bring all of this home now for the learner. Whether you are a nurse, a student, or a super prepared parent, how do we apply this? Let's look at some key exam topics and clinical scenarios.
Let's start with the holy grail of toddlerhood, toilet training.
The ultimate struggle. So, when is a child ready?
Exam writers love this question because it's not just about age. You can't just memorize age 2. It requires a convergence of 3 different domains: physical, cognitive, and motor.
Okay, break that down for us.
So, physically, they need voluntary sphincter control. This usually happens after they are walking, sometime around 18 to 24 months. A key sign is that they are staying dry for at least 2 hours at a time during the day. If their diaper is wet every 30 minutes, the bladder capacity just isn't there yet.
And cognitively.
They have to be able to recognize the urge before the event. They need to connect the feeling of a full bladder to the act of needing to go to the potty. If they only tell you after they've already gone in their diaper, they aren't quite cognitively ready.
And the motor aspect.
This is the one people always forget. They have to be able to remove their own clothing. If they can't pull their pants down by themselves, they aren't ready for independence on the toilet.
So if a parent asks, he's 18 months, should I start? The answer is?
The answer is more questions. Is he waking up dry from his naps? Does he tell you when he needs to go? Can he handle his own pants? If the answer to those is no, then you wait. Forcing it too early just leads to frustration and shame, and there's Erikson again.
Next topic, nutrition and those infamous food jags.
Yes. The all-beige food diet, the dinosaur nugget phase. A food jag is when a toddler will eat only one specific food for days, sometimes weeks at a time, and then suddenly refuse to ever touch it again.
It drives parents absolutely insane.
It does. But the strategy comes right back to autonomy. Do not force feed. That creates a power struggle you will lose. You provide healthy choices, you keep offering variety, and you completely ignore the refusal. Remember, because of physiologic anorexia, they will not starve themselves.
And what about milk?
This is a very specific guideline. Whole milk from 12 to 24 months. No exceptions unless there's a medical reason.
Why whole milk specifically?
Because their brain is still myelinating at a rapid rate. Myelin is the fatty sheath that covers all the nerves and speeds up processing. You need dietary fat to build that crucial brain architecture. After age 2, you can switch to low-fat or skim.
And juice.
Limited. Severely. 4 to 6 ounces a day, max. It's essentially sugar water with no fiber. It fills them up so they don't eat real food, and it's a huge driver for cavities.
Okay, brace yourselves. We have to talk about the pokes, the vaccine schedule.
The 12 to 15-month visit, this is the heavy hitter.
Yeah, looking at the CDC 2025 chart here, there are a lot of acronyms. It can be overwhelming.
There are, but for the one-year visit, try to group them. We often use a little pattern recognition trick or a mnemonic. Harry's Vax, MD, or something similar.
Walk us through that. What are the core ones?
Okay, so the big ones you're almost always giving at this visit are H for Hib, P for PCV, that's the pneumococcal one. You have M for MMR, measles, mumps, rubella, and V for varicella, that's chickenpox. And finally, A for Hep A, the first dose of hepatitis A.
So Hib, PCV, MMR, varicella, and Hep A. That's potentially 5 shots right there.
It can be. And usually the DTaP booster comes a little later, around 15 to 18 months, but sometimes it gets grouped in depending on the clinic schedule. But the core one-year milestones are definitely MMR, varicella, and that first Hep A.
Why do MMR and varicella happen now? Why not earlier?
It's all about maternal antibodies. The immunity the baby got from mom in the womb starts to wear off right around the first birthday. If we give the vaccine too early, mom's leftover antibodies might just attack the vaccine virus and neutralize it before the baby's own immune system can learn from it.
So you have to wait for that window to open.
You have to wait for that window. And Hep A is a 2-dose series, right?
Correct. The first dose at 12 months, and then the second dose has to be at least 6 months later. It's a lot for a little leg.
It is. But you have to remember the why. Toddlers are exploring the world, putting everything in their mouths. It's a huge HEPOish risk. They're starting to play near other kids, that's MMR and varicella risk. This is exactly when their immunity shield needs to be fully activated.
One last clinical scenario, sibling rivalry. We touched on regression, but what is the practical advice you give to parents?
It's the dethroning of the king or queen. The toddler feels displaced. Their entire sense of autonomy is threatened by this new creature. So the fix is inclusion.
You give them a job.
You give them a job. You are the big helper. Can you please get me a diaper? Can you pick out the baby socks? You have to validate their new important role.
And boundaries.
Yes. Practically, you do not let them use the new baby's equipment. Don't let them drink from the baby's bottle, even if they ask. It just reinforces the regression. You want to keep their big kid status elevated. Oh, that's for the baby. You get to use a big boy cup.
That makes perfect sense. Okay, we have covered a massive amount of ground. From the closure of the anterior fontanel to the existential crisis of a table being bad.
It's a really dense, critical period of development.
So let's wrap this all up with our 80-20 summary box. If the listener remembers nothing else from this entire deep dive, what is the core concept?
If you can understand that a toddler is an egocentric, autonomous explorer who desperately wants to do everything themselves but lacks the cognitive judgment to do it safely, you can answer almost any question you'll ever face.
Let's bullet point that one more time.
Okay. They say no to assert, that's autonomy. They play beside other kids, not with them, because they can't see the other's point of view. That's egocentrism. They get hurt because their motor skills are way faster than their brain. That's the impulse control gap.
And they fall apart when stressed?
And they regress when stressed because those rituals provide the safety they need to be brave enough to explore in the first place.
See? It's not just chaos, it's logic.
Absolutely. It all connects.
Before we sign off, I want to leave you with one final thought to chew on. We talked about animism, the idea that the table is bad because it hit me. Think about what that does to a child's early understanding of justice and blame. If an inanimate object can be guilty, how does that shape how they view the world? And to take it deeper in a hospital, if a syringe causes pain, is the syringe itself evil? Is the nurse holding it bad?
It really highlights why building trust and using therapeutic play is so vital in pediatrics. You're literally battling a worldview where everything is alive and potentially out to get them.
That's heavy stuff for a kid who just wants a cookie.
It is.
Well, that is our deep dive on the toddler. Exhausting, exhilarating, and the ultimate scientists, testing the laws of physics and sociology every single hour. Thanks for listening, and good luck with your own little scientists.
Stay safe out there.